to sustain measles herd immunity. Considering these trends, any policy decision that compromises the clarity or consistency of vaccination guidance for MMRV has the potential to further diminish public confidence. I think that's really important in your deliberations. And answer some of the questions that you may have had for us. The one point I would make is that there was one question about what do we understand about the immune response and why was there a higher amount of antigen for varicella that was put in MMRV. And it's important to note, the increased antigen was only for varicella. There was no change to the antigen content for MM or R in the combination vaccine. And it's essentially related to what was needed to demonstrate an appropriate immunological response to show non-inferiority of the immune response of MMRV compared to the separate MMR and V. And it's very likely that this relates to local interference of the antigens when they're given in the combination product. That's all from me. Thank you.
Thank you. I would like to make one correction to make sure that credit is given to where credit is due. The discovery that MMRV had an excess risk of febrile seizures compared to MMR was done here at the CDC. So it's the CDC that deserves the credit for finding that out. It was done through the Vaccine Safety Data Link and its rapid cycle analysis, where the CDC evaluates new vaccines with weekly data feeds. And it was detected, I think, after about 25,000 doses. So it was a very quick detection, and it shows the excellent work that people here at CDC and in this particular VSD is doing to monitor the safety of vaccine. Are there any other comments or questions on this presentation? Dr. Hibbelin.
A brief comment concerns that we are looking at a risk benefit of febrile seizures, which may or may not have long-term consequence, likely not, as compared to falling below a 90% coverage rate for herd immunity. And the consequences of that are devastating for pregnant women losing their babies, newborns dying, and having congenital rubella syndromes. And that it seems that we have to be very careful of driving this non-vaccination group below 90%. Appears we have to be very conscious that this may be driven by fear and may be driven by most people, the fact that most people don't think about, they think of vaccines being either good or evil. And either I should have my child vaccinated or not vaccinated. And they don't understand the discussion of the subtleties that we're going through. So if we make a major change in what has been a very vaccine campaign, I think we have to have a darn good reason as to why we're making that change from what Corey Meisner out and access. We had better have a very good reason as to why we'd change that advice.
Thank you. And I think we can move forward now to the proposed recommendations and a discussion of those. If we can get those proposed recommendations up on the screen, that would be great. I would like to stress that in this vote, we are not voting on any changes in what diseases children are vaccinated against, nor are we proposing any changes in the timing of these vaccines. So that's not part of the vote or discussions. One can have different views on that, but that's not part of what we're doing today. So the vote is on the pediatric vaccine schedule should be updated to reflect the following change. For measles, mumps, rubella, and varicella vaccines given before age 4 years, the combined MMRV vaccine is not recommended. And 2, children in this age group should receive separate measles, mumps, rubella vaccine, and varicella vaccines, MMR plus B. And again, we are neither voting on children above 4 to 6 years because we know that there's no difference in the risk of seizures among those older children. So this is the vote, the proposed vote. And do we have the discussion now then before we do? Oh yeah, okay. But we have the discussion now of this, and we are voting not until the end of the day after public comments. Dr. Stein?
Could you clarify how this is different than the current recommendation? Because the 2009 recommendation sounds like the two separate shots.
So there's two main differences. One is that the current recommendation says that both are recommended with the preference for MMR plus V. The other one is that some children get a second dose before age 4. For example, if there's an outbreak, a child might get a dose at 7 months of age, but then they have to be, because it doesn't have the efficacy, so it has to be, then get a dose again at 12 or 15. So then that's the second dose. So they will also, so right now, so they will also change so that everybody who gets the dose, whether it's the first or the second dose, it will be not, MRE will not be recommended, whether it's first or second dose. Those are the two differences. Dr. Levi?
Yeah, so the way I think about it is, let's say that someone would guarantee us that the adherence would be the same. Let's just for the sake of discussion. It seems to me quite reasonable that most of us would think that the separate vaccines are better because there is some harm or adverse events that are being caused in excess. I think some of us maybe feel more kind of comfortable that they know and they understand that it's just like a local impact of that event, and some of us are more concerned. But I suspect that if we would somehow be guaranteed that all things are equal between these two options, the adherence is the same, I think the choice would be clear. So that kind of brings to me, in my mind, the discussion to what extent we believe that two separate doses are going to have materialistic impact on adherence. And I'm not fully convinced which fact. We are all concerned on reduction in adherence to vaccines, but it's not clear to me that the fact that we see a reduction suggests that the reduction would come or would be affected by the fact that we separate these two vaccines for the first dose. In fact, I actually tend to believe more that safer and less adverse events are going to increase trust and adherence. So that, given that at the very best, I don't think we have good evidence either way, I would go with the option that seems to be safer, that also gives lower quantity of the antigen to the children. I think that that's something that makes sense to me.
Thank you, Dr. Petsworth.
I just want to clarify that currently 85% of the first dose is 15% of vaccinations at 12 to 15 months is currently MMRV, correct? Okay.
Yes, that is correct. And I want to sort of give praise to the pediatricians because they have both options, but 85% is choosing to administer the MMR plus V because of the fewer seizures. And just an anecdotal thing, when my twins were vaccinated, I asked the nurse if it was the MMR-V or the MMR plus V, and she said, "Oh, it's the MMR plus V because," and she gave us exactly the correct reasons for why that is the case, without knowing that I do vaccine stuff. So she knew her stuff, and of course the physician in the office knew his stuff. So I think we should praise the pediatricians and the nurses who are 85% are sort of trying to minimize these febrile seizures. I think we're actually a little bit ahead of schedule, so that's good. Oh, okay, Dr. Meissner.
Thank you, Dr. Kuldorf. And let me make two comments here. First, I would like to go back to your statement, which I agree with, just to clarify that the recommendation to give measles, mumps, and rubella before 12 months of age is for young children who are traveling with their family to an endemic area and might get exposed to measles. And that should not be included as part of the two-dose series. That a child who gets an MMR before 12 months of age, as you correctly pointed out, still needs to get a second and a third dose. And but I just wanted to make sure that was clear to everybody. And I also want to point out that the MMR-V vaccine, that is the tetravalent or quadrivalent vaccine, is not licensed before 12 months of age, and it's not licensed after 12 years of age. So it can only be used in that window. The second point is that I wanted to say is that just taking the other side of the first bullet here, what we're saying is we don't trust parents to make a decision. Some parents don't want to administer 2 doses of a vaccine if they can receive one and get the same degree of coverage. And I'm not sure. I mean, I prefer that families have the option to make a selection. And if we go with the first bullet here, that won't be an option. We know that most are getting, as we've said, 85% are getting the 2 doses. But if a parent wants to get a single dose, why are we taking away that option? Over.
Thank you. Thank you, and Dr. Goldman.
Thank you so much. I will reiterate the question I asked at the last meeting. Are we going to have a thoroughly vetted evidence to recommend framework presentation that looks at all the harms, benefits, acceptability, feasibility with input from practicing clinicians and liaisons in order to make an informed decision? I would argue that this recommendation is going to create more confusion among the public. It does not involve the aspect of actual practicing clinicians and how we deal with vaccine hesitancy and how we talk to our patients. And also, when you make this recommendation, you now give license to insurance companies and the Vaccine for Children's program not to cover this vaccine. And finally, you are taking away the choice of parents to have informed consent and discussion with their physician on what they want to do for the health and benefit of their children. So I urge this committee not to change the recommendations if they truly want to give the power to the parents to decide what is best for their child and allow them to make the choice in consultation with their physicians. And if we are going to have these recommendations, I urge the committee to go back to the very well done evidence to recommend framework that we have apparently, so we can have that debate and discussion that you requested at the beginning. Thank you, Mr. Chairman.
Thank you. And Dr. Hopkins?
My comment.
Thank you. Dr. Middleman?
I would also like to echo Dr. Goldman's cogent comments. It is critically important that we present all available evidence to make these decisions in one coherent, scientifically vetted presentation so that all providers and patients can understand the full breadth of information. It's so important to talk about what the evidence shows versus what people may believe that is not necessarily supported by the evidence. Thank you.
Thank you for that. My personal view is that we had two very excellent and informative presentations by Dr. Srinivasan and Dr. Su, so I thank them for that very much. We will have one other short presentation from the VF.
So can follow-up question on this?
Okay, yeah.
I would be interested, really, truly. Can you articulate what information is missing from that was not discussed or considered? Because it seems that you made very strong statement that suggests that there is information that is not being considered here. Are you disputing the evidence that there is increased fibrous seizures after the MMRV, or what is the additional data that you feel was not considered currently?
Well, if I may, it's more than just the data considered. It's also the clinical experience, the work groups. All the liaisons have been removed from the work groups. You do not have those subject matter experts with the real world experience to understand the implementation of these vaccines and the concerns of the patients. You don't have the voice of the patients we take care for. You're not looking at all of the aspects of how we evaluate vaccine implementation. You're looking at very small data points and misrepresenting how it works in the real world and how we take care of our patients. So no, this was not a thoroughly vetted discussion. I want to see how we implement it, how it's accepted by the population, what's the feasibility, what's the equity in this presentation. There's something to be said about physicians' real world experience with their patients.
Dr. Middleman?
Sorry, I had taken my hand down because Dr. Goldman was handling it beautifully, but I echo his comments. And we really need to see all of the data together with the vast breadth of scientific data that does not just include the few studies that were presented here.
So I just have to respond to that I trust the CDC staff that they brought all the relevant data to the question. I'm sure we can trust them. And I also look, and some of my colleagues, and I think that some of them are pediatric doctors and have experience in caring for patients. But if you will be able to articulate missing data, I think all of us will appreciate hearing about this. So thank you.
May I respond to that?
We'll have Dr. Hopkins first.
I certainly appreciate the data that was presented by our CDC colleagues as being thorough and informative, but we've not considered issues around equity. We've not considered issues around the implications of these decisions for our patients and for the practicing physicians who are carrying out these actions. Those missing elements in going through the full evidence to recommendations framework does not provide us a full opportunity to review all of those elements. Thank you.
Dr. Goldman?
Dr. Hopkins said it perfectly.
Okay, so thank you, and I'm glad we're having this discussion. We will now move forward to a short presentation by the VFC. I'm not sure who is presenting from. Okay, I think it's in the process here, so take your time. And if you give your name before you start the presentation, good, thank you. Okay, while we are waiting, we have another comment from JSHLAY. So if you can go ahead.
This is Dr. Schleif representing NACHO. I just want to bring up one comment that I think is important for the practicality of this recommendation. At that age of 12 months, the young children are getting a number of vaccines. So we're adding now an additional one. And some parents want to have fewer injections. We can be giving up to 7 vaccines at one time for a child. And so we want to make sure that we have informed consent about what the parent wants. And that's a very important consideration for me on the front lines giving vaccines. That's very important when you have children that need so many at a certain time.
Question.
Dr. Stein?
So I pulled up the vaccine information sheet, and it does say that there is an increased risk of fever and seizures after the 2 separate shots. And I understand the epidemiologic concepts are really hard to explain to most people. I'm just wondering, and since we have the medical professionals on the line, like, how is that actually communicated? And is there sometimes, I'm very seriously curious, is there sometimes a rush? Like, is it hard when you have a line of patients coming in to clearly provide informed consent on that? Yeah, that's good too.
I think that you could hear from a doctor and we might say one thing. I think what would be fair is to ask the patients how many times they felt all the risks and benefits of any vaccine or medicine was given to them. When we gave them Bactrim, do we tell them the risk of Stevens-Johnson syndrome? Do we talk about all the different things about when we treated an illness we thought was probably virus but might have some viral activity? Do we tell them when we gave them amoxicillin they might get a rash from that if it's EBV? I think the people who really know this are the parents. And what I hear from the parents most of the time is, I didn't hear anything. I think that's honest. And I think if they were to say that we're doing the best we can for your child, this is the best thing. This is what's been recommended. This is the best thing. Okay, it's a busy practice. I think if we're honest about informed consent between physicians, PAs, extenders, pharmacists, I believe we are probably failing to meet the standard of true informed consent.
Thank you. We're going to try with the VFC. Do you have it ready to go?
Martin, can I
We'll
make
do that now? We'll go with the VFC right now. Thank you.
Good afternoon. My name is Jeannie Santoli. I'm going to walk you through the VFC resolution update. Next slide, please. So we're going to go through this, and everything that's shown in red font is the change from the resolution that's currently approved. Next slide. So the purpose of the resolution, of course, this is all new, and the purpose of the resolution is to update guidance on the use of combined measles, mumps, rubella, and varicella vaccine. Next slide. Because there's 3 types of vaccines in this resolution, there are 3 components. There's one for the measles, mumps, rubella, one for varicella, and one for the combined. So we're going to walk through these. There are no changes in the first two components of the resolution. Next slide. So this is the eligible groups for the MMR component. Next slide. This is the recommended schedule for the MMR component. Next slide. This is the dosage intervals and dosage. Next slide. This is the contraindications and precautions. Next slide. For the varicella component, the eligible groups, no changes. Next slide. For the recommended schedule and dosage intervals, no changes. Next slide. For the dosage, contraindications and precautions, no changes. Next slide. Now for the combined measles, mumps, rubella, and varicella component, the eligible groups would change. Children at least 4 years through 12 years. This had previously been 12 months on the lower end. Next slide. For the recommended schedule and dosage intervals, we will be removing a link to a previously approved recommendation. And the language that you see here is the language that was just voted upon. I'll give you a minute to look at it.
We didn't vote.
Oh, I'm sorry. I know. Okay. I'm sorry. And you're not voting now. My apologies. It's the language you just discussed that for a potential vote. My apologies. Sorry. Next slide. And then for the dosage intervals, we're also removing a link to a previously published statement. There's no changes to the recommended dosage or the contraindications and precautions. Next slide. This final statement is included in the VFC resolutions in general, that things that are published after the fact within 6 months are incorporated by reference. There was a typo here and it was 12 months and it was supposed to be 6 months. So I was using this opportunity to correct that typo. And that concludes my presentation.
Thank you very much. And as is common, when we do vote, there will be 2 votes. First, 1 vote, and then there will be a vote on the VFC. So that's a sort of standard procedure that it does that. Yeah, similar to what we did in the June meeting. So we have Dr. Griffin. We have a few more minutes before lunch break. So,
Thank you. As far as practical experience is concerned, I'd like to echo comments of Dr. Mulhone. As a mother, it was often just commented as I came in with my children, it's time for their shots. And no additional description. VIS, the vaccine information statement, was given to me at times, not consistently every time, with the expectation, of course, that you read it when it's in hand, but not explained. I understand this may be a bias because I'm a physician. What could have been understood or expected that I understood this already. But I asked many of my patients and friends that are non-physician or not in the medical field, and they had a very similar experience almost across the board. And this is, of course, anecdotal. As far as the extra data, I believe everyone in this committee would be very open to extra data to review. And I will echo my earlier comments regarding and I apologize if I misspoke regarding a randomized controlled trial. I understand and know that, of course, the ethics behind the conduction of these trials. That is why I feel that we need to expand the studies that we look at and the raw data that we look at in our considerations to that point of having more considerations, more experiences. All of these collated statistical analyses started from one anecdote. And that's how we look at these children, is individuals that then collectively have either rendered benefit or succumbed to risks. Thank you.
Thank you. We have time for 2 more before lunch. Dr. Schley?
Yes, I just wanted to comment. When I'm just going to speak in our clinic at the Public Health Institute, Denver Health. We run a large-scale immunization program. We give the VFC form, VIS form beforehand. We go over it and then we vaccinate. So people have informed decision about vaccines. It is the requirement that the VIS is given prior to vaccination, and that's something that we follow. And I think local public health agencies throughout the country do the same thing. I can't comment on anecdotal information, but that is the requirement, and we try to uphold that.
Thank you. I'm going to correct myself. We will do 2 more from now. So, Dr. Middleman.
Thank you so much for recognizing me. I just want to be really, I just want to make sure that people understand in the public that there is a breadth of data, many studies that address the process that used to take place, the evidence to process that the Advisory Committee on Immunization Practices specifically used to make sure people were aware of all elements of a public health discussion. A public health recommendation should never be based on anecdotal evidence because, as you all know, the physician has to worry about an individual patient, but public health providers have to worry about the health of the entire public. It's really important to make sure all elements of public health are considered, including the public health import of the disease, the risk and benefit of the intervention, the feasibility of the intervention, the acceptability of the intervention, and the cost-benefit ratio, as well as equity. I would urge the committee, I haven't heard any information about urgency related to this decision. I'm not sure why it has to be made today. I would urge the committee to follow the methodical process of an evidence to recommendation process before voting on something that affects the public health to this degree. Please do that for public confidence and in order to make sure the science is adequately and appropriately vetted. Thank you.
I guess I should apologize for that anecdotal thing about my twins when they got vaccinated. But I think we have had a very good discussion here, very science-based. We had excellent presentations from our CDC colleagues, and I think there's been an excellent discussion about a variety of aspects of these vaccines. So now the last person is Dr. Petsworth.
I just wanted to say that I do recognize that at the 12 to 14 month visit, I believe it was the liaison from NACHO mentioned that many vaccines are given. And so that is impressive in the sense that already 85% of pediatricians and parents are choosing the MMR plus the V separately. So there's that. The other question I have is sort of a technical one. The language that was posted for the vote, it says recommends. Does that doesn't mean though that the MMR-V that is licensed by FDA is prohibited from being given to certain patients? So I just want to make sure that the pediatrician or whomever would have the option of choosing to give a licensed product that do you know what I'm trying to ask? Yeah.
So this recommend, it is FDA who decides what can and cannot be used.
Right.
That is the case for all vaccines. Our vote does have consequences sometimes on insurance coverage, including from CMS. So that is a factor. But it is FDA always who decides what is allowed to be given and what's not allowed to be given. That is not, we do recommendations. So thank you. So I think it's
to have our VFC colleague comment on how the ACIP recommendations impact the vaccines for children because they pay for a large number of pediatric vaccines.
Please do.
Sure. Thank you. So actually, a recommendation that says something is not recommended means that it will not be covered by the VFC program for use in children. If there are ways to talk about individual-based decisions where you can actually have that coverage, but as it is written now, the VFC program, if the resolution that I shared that you will vote on later, I know you have not voted yet, actually would mean that VFC would not cover this vaccine, even if a parent chose that was what they wanted with their physician. And
Yeah, that is the correct information. So thank you for saying that. From CMS, can you state your name?
Yes, Andrew Johnson with CMS. I would also further add that it would have coverage implications in the Medicaid and Children's Health Insurance Program, and could also have in individual and group markets have effect for either coverage overall under the first bullet category, or could have impacts for out-of-pocket copays, for example.
Thank you for that. And just to be clear that this is coverage for the MMRV vaccine. There will be no changes in the coverage for the MMR vaccine nor for the varicella vaccine. So they will be fully covered just as before. There will be no changes there.
That's correct. It would not have any on the second. There would be no implications there. Simply on the first.
Yeah, nothing, no implications either on the second dose. Correct. We're most of
on the second dose. You are correct, Mr. Chairman.
So we do need a lunch soon because I think many of us are hungry. But Dr. Hebel.
So just to be clear, in the point for the proposed change that measles, mumps, and rubella vaccine given before 4 years of age is not recommended, that means that it would not be paid for.
in the Vaccines for Children program, it wouldn't be covered
It wouldn't be covered.
for children who are under 4 years of age.
Okay, so that implies that the parent's choice, unless they want to pay for it themselves, the parent's choice is taken away. If parents would choose to have one jab and one vaccination,
It would
for
not be
whatever
covered by the
reasons, if
VFC
they have
program.
hard time accessing
Mhm.
clinical care, if they understand the risks and benefits, that option is basically taken away from them in many.
Right, VFC would not cover
Okay,
the vaccine for
got it.
those children. Yes.
Okay.
Yes, sir.
So thank you, everybody, for this very interesting, thoughtful, deep, and spirited discussion. That's exactly what we want at this ACIP meeting. We will now break for lunch, and we are reconvening here at 5 minutes past 1 o'clock. So thank you very much, everybody.
That's an exotic experience to everything. My interest in something. So how do we usually handle?
20 minutes. So got it. Awesome. Mark, you ready? Let's go and keep moving along. It's something.
and it is our power. And I say this as someone who has protested on the streets of my district, has been tear gas, mace, arrested, and jailed in the jail I now represent in Congress. So this is very personal to me. We cannot let the fear of speaking out become normal. We cannot allow truth-telling become a crime, and we cannot let them silence us. The NOPE Act is about strengthening the laws that protect the people from an administration that fears truth and fears democracy. An administration that wants to divide our nation, divide the working class, to distract from the fact that they're doing everything they can to enrich billionaires and to enrich mega corporations. That's exactly what happened with Jimmy Kimmel last night. The Oversight Committee will have more to say about this, what happened last night. But look no further than the fact that Sinclair is in the middle of an acquisition that the FCC has to approve. All of this ties back to money and people enriching themselves and bending the knee to Donald Trump to make it happen. This bill will give us another tool to fight back. And while congressional Republicans lie down and do nothing and enable this, Democrats will be advancing this bill, launching investigations, sending subpoenas to expose the ever-mounting corruption. When we don't have all the power we want, we use bill is about. When we use every tool we have, especially our freedom of speech, to stand up to the onslaught against the American people, we can win. And I encourage my Republican colleagues to join us on this. Thank you.
Thanks. Maxwell, I'd be happy to take any questions.
Senator Murphy, it's not only just President Trump who's doing this, but a lot of your Republican colleagues in the House tried to censure Ilhan Omar last night. They're calling people's employers. How can you not only do protections for people who are targeted by the president, but members of Congress and anybody who's trying to go after and get people fired for their jobs?
Yeah, I mean, this is going to be an epidemic where there will be speech control, both in the public sphere, but in the private sphere as well. These corporations are so greedy that they are willing to do anything and everything in order to make as much money as possible, including being lieutenants in Donald Trump's effort to try to control political speech. So listen, we need to be talking not just to President Trump and the broad public, but to the corporate community as well, and put the question to them. You're going to rue this moment. You're going to regret this moment on your deathbed when America is no longer a democracy anymore, and you were willing participants in the effort to destroy political speech, either by shutting down voices like Jimmy Kimmel that had every right to be able to speak in dissent to the president, or patrolling the speech of your employees who have just as this is a big job because we have to be speaking to our Republican colleagues to get them to do the right thing. We've got to be talking to the public, but we have to be talking to the corporate community as well.
Thank you. I know where you stand, but is your leadership willing to shut down the government? Because, as you know, you all fund the FCC over this. I mean, they need your votes to keep the lights on.
Well, listen, Republicans won't even talk to Democrats right now about how to keep the government open and operating. So right now, it's clear that the Republicans are gunning for a shutdown, because if they wanted to keep the government open and operating, they would be having conversations with Democrats. I'll just speak for myself. I do not think Democrats have an obligation to fund the destruction of our democracy. And so, of course, for me, I am going to require that there be at least some modicum of protections for democracy in any budget that we pass. Obviously, why would we write a budget that the president isn't even committed to implementing? Why would we fund this level of lawlessness at a moment that the country is under threat? I guess that wasn't the right answer. So, go ahead, we'll take a couple more.
Okay, so if Democrats were to get the gavel before Carr's term is over, what does that mean? Schumer has called for him to resign. So do you guys have any power to see a path forward for, handling the Carr situation?
Well, it's been pretty remarkable how honest Brendan Carr has been. He's making the rounds of right-wing media, essentially celebrating the fact that he is using in an illegal manner the power of his position to shut down political speech. He really doesn't talk too much about hate speech or violent speech. He just is clear that he's trying to silence progressive voices. I think that creates a real political problem for the president, but also a legal problem for the FCC. So the more that Brendan Carr talks, the less likely it is that their actions are going to be able to hold up in court.
Senator, one argument that we've heard from conservatives today regarding Jimmy Kimmel is that the Biden administration did the exact same thing when they pressured companies like Meta and Google last year to censor, in the last few years, censor information related to COVID. So what would you say to Republicans, your colleagues who are saying this?
Yeah, that's simply not true, right? To try to equate making sure we get out good information and appropriate information versus the propaganda and the misinformation and the lies that are being put out by this administration are simply not the same thing, right? We're looking for freedom of speech. We're looking to protect it for everybody. And what we're seeing is an unprecedented effort to crack down on all speech. As our colleagues said, almost regardless of the source, right? Right now, it's Democrats and it's progressive organizations, but it also has been conservative organizations. It's anybody who dares question the authority of this president, whether there's an R or a D or a U behind your name. Right into the first question, this is not just a story about a runaway president who's looking to abuse and consolidate power, right? Because that actually was envisioned in the Constitution. And that's why the Constitution was built the way that it was, to distribute that power. Because there are a lot of people who do have power. The majority of this Congress has the power to stop it right now. Big businesses, universities, law firms, media conglomerates, they face a choice. They can stop it and stand in the breach right now. But if they don't right now, 3 months, 6 months, 1 year later, everybody starts losing that power over time. So now is the moment to use it.
Take one more go.
Thank you, appreciate it. I'm going to try and sneak in two and do the White House reporter trick, but I'm happy not to do one. Kind of just the best, what I'm saying. Two questions as a reporter. Two questions. One, in terms of what you all can do, you said that some said the FCC commissioner should resign, but should he be impeached? That is potential motion on the floor that could be accepted for House members especially. Number two, what is Democrats' responsibility for the rhetoric right now? We heard your fellow member, I'm sorry if he left, talk about fascism, saying we're having fascism now. We know the suspected shooter in Utah, one of the rounds of artillery. Republicans say that Democrats are part of the problem right now because of using words like Nazis and fascists. Those are the two questions.
Well, listen, we have to tell the truth. And the truth is hard to hear right now. The truth is that Donald Trump is trying to destroy our democracy. He is trying to silence free speech. He is acting in a way that is scarily similar to many would-be despots all across this world, all across history, who have tried to transition a country from democracy to autocracy. And so we have no obligation to sugarcoat the gravity of this moment. The only way we save this nation is if the people of this country rise up in peaceful protest, if they mobilize all across America. These companies won't really think twice about their money grab until they know that the American people are firmly on the side of protecting free speech. And so the only way that you build that kind of mobilization is to tell the truth. So this is another tried and true tactic of despots, is that they label any criticism of them as hate speech or terrorism or incitement to violence. This is how democracies disappear, is that you allow the regime to create terminology that essentially invalidates the ability to speak truth to power. And we're just not going to let them silence us. I don't know if you want to take the, yeah, great. All right, thank you, everybody. Appreciate it. Thanks, guys. Thanks, everybody.
Sorry. Good afternoon, everybody, and thank you for joining us. Today, we're launching a long COVID consortium, and it's in response to interest from a couple of senators, Senator Young and Senator Marshall, who's here, who have a deep interest and have been talking a lot about this issue, but also in response to my own personal experience and the calls that I get almost every day from people who are suffering from long COVID across the country and don't know where to go and feel that their voices aren't being listened to, including members of my own family. We wanted to do something different in response to this pandemic. In the past, the response to epidemics of this kind has been to pump a lot of money into ivory tower science to try to solve the problem. We've already put $1.5 billion into NIH to solve long COVID, and we've got literally nothing from it. And one of the mistakes that we've made in the past is to not talk to the doctors who are actually treating the disease. During the HIV epidemic, there was a policy in the federal government to simply stop talking to those doctors and to discredit them. There was extraordinary science going on, and with particularly with the gay doctors in New York, San Francisco, and Los Angeles, who are finding great success in treating their patients. And those doctors were shut down in the process, but also there was an initiative by the federal public health agencies to shut them down and to deny access to the repurposed drugs that they were using to treat patients very successfully. There was a movie called Dallas Buyers Club that was made about this. And my uncle said that Senator Ted Kennedy actually became an advocate for those patients and ultimately made an agreement with Dr. Fauci, who was shutting those doctors down, to fast track the treatment testing, clinical testing of the repurposed treatments, the off-label treatments that they were having so much success with, and to allow patients to get access to drugs that they and their physicians believed were going to be helpful and not having to import them from Mexico or Europe or Canada. The same thing happened during the COVID pandemic, where repurposed drugs that were being used by physicians across the world and being used very, very successfully were not only not investigated, but they were shut down and people's access to them was denied. And we want to make sure that that mistake never happens again during disease crises, during contagion crises, and that we start listening to doctors who are on the front line and the doctors who are treating patients successfully all over the world. There's approximately 15 million frontline physicians in the world, and many of them are imaginative, they're great healers, and they find solutions that the ivory tower often doesn't see. And so we want to, first of all, open up a dialogue with those physicians and then give us some mechanisms for assessing the efficacy of their treatments and doing the other things that we need to do. For example, to identify biomarkers, to identify and characterize symptomology. Right now, CDC lists about 300 symptoms to long COVID, and people, virtually everybody falls into one of those categories. And we want to do everything that we can to narrow that constellation of symptoms, and then to be able to assess these unconventional treatments and protocols that people are using, and find out from the patients themselves, from the physicians themselves, which ones are working. So this is partially a listening session, but it's a lot more than that. It's a session in which we are seeking to find alternatives. We're seeking to find solutions. where we want to, for example, start a website that helps Americans locate doctors who are successfully treating these diseases, and gives us a way to assess the success and the efficacy of those treatments. And we don't know exactly what that's going to look like. And one of the reasons we wanted to meet with these people, this esteemed panel today, is to get their ideas about how to construct a website that will really be useful to patients and physicians around the country, and that will give the public health establishment an ability to evaluate the success of various protocols. So I want to welcome all of you today, and let's begin by introducing ourselves. Maybe Dr. Redfield, you would start. We'll go around clockwise.
I'm the former CDC director. I'm an infectious disease physician by training, and I'm currently involved in clinical practice largely for long COVID and mRNA vaccine injury.
My name is Holly Olson. I am a long COVID survivor, and my kids and I all have long COVID from Utah. I'm also a registered nurse with a bachelor's in science and have done a lot of research on this. I've had my journey of the long COVID affecting my connective tissue and all of my body where I could not even walk or move. Have utilized lots of different treatments and have found that stem cells and have helped quite a bit, ethical sources of stem cells. So I wrote a stem cell bill for Utah, which allows treatments to be done in Utah, and have passed another one in Florida, and I'm working in other states. I've also have found that monoclonals have been a huge helping factor in calming the immune system down, along with peptides that have been also very helpful, and hyperbaric oxygen therapy has helped me and my kids and several of my long COVID friends. We are just grateful to have, be able to discuss this and to get some ideas to get people better, and I appreciate this time.
Hello, Mr. Secretary. Thank you for having me. It's an honor to be here with you all. My name is Devin Russell. I'm a co-founder of the Long COVID Foundation. Thank you for affording me the liberty to wear my mask. I think once I explain my history here, you might understand why I would wear one. First, I want to hand out a one-pager on some of the long COVID community needs. I had long COVID starting in March of 2020. I've had it for 5.5 years now. I did not take the COVID vaccine. I alone have had 170 plus symptoms, some very severe, Guillain-Barré, blood clotting, heart issues, brain dysfunction, and even delirium at a time because my brain was so inflamed, which it still is inflamed, but not to that level, but it's still a problem for me. I was near death at times, and that's not a hyperbole. I thought I was going to die. Prior to that, I had chronic Lyme for 11 years, which I recovered from, and I managed a chronic illness-centric clinic for 4 years. So based on that experience, I can tell you long COVID is a unique kind of hell. This is an urgent crisis that needs action now, as I'm sure you know. People are suffering and even dying, and a lot are holding on by a thread. So some of the things we need, of which there are many, but well-run common sense trials, biomarkers and tests, and development of antivirals and other drugs, because we have no tests, no biomarkers, and no treatments right now approved. So I look forward to discussing this in more detail today, and thank you.
Thank you.
Good afternoon. I'm Darcy Johnston, the Principal Deputy Director of the Intergovernmental and External Affairs Office in the Office of the Secretary.
Hi, Ken Callahan, Head of Policy for the Secretary. Just want to thank everyone for coming, and this is something the Secretary has been very adamant and focused on making sure we brought together a roundtable of physicians and patients and other advocacy groups to make sure he could hear directly from them. This is something also he has stressed he wanted to make sure was live streamed so is open to the public, part of his campaign to make sure there's radical transparency. And then also just wanted to address the invisible illness, which there are many in the U.S., and Secretary and the team here is committed to making sure that we get a voice for everyone who is suffering from them. Thank you, everyone, for coming.
I'm Jim O'Neill. I'm the Deputy Secretary of HHS and Acting Director of CDC. So here in this room, you have the heads of 4 of our science divisions and 1 of our data divisions. We're all eager to learn more about long COVID and do excellent research and come up with solutions for everyone. So I'd say long COVID is in the same clinical category as Lyme and Epstein-Barr and chronic fatigue syndrome, which is no consensus yet on biomarkers, no consensus yet on diagnosis, no consensus yet on causes or treatment, but definitely an important, urgent challenge that we need to discover everything we can about it.
I also want to mention, and we're going to do a very similar roundtable, I think, next month on Lyme disease, which has a lot of interactions and similarities.
Right. Thank you, Mr. Secretary. Roger Marshall from the great state of Kansas. I'm here today representing and speaking for, fighting for the 20 million Americans with long COVID. And it is personal, just like your stories, Mr. Secretary, in that I've had a loved one with long COVID for 3 years. And I want to take a moment to acknowledge some of the people in the room. It's different being the doctor on the other side rather than trying to help somebody out. It's been very humbling, but I'm so grateful for them. We've reached out to hundreds of doctors and tried to figure out who could help my son, and acknowledge Dr. Jordan Vaughn here, who's kind of the pioneer of vasculitis. Something as an OBGYN, we talked about pelvic congestion syndrome and cardiac output return. So great to see you, Dr. Vaughn, here. And out in the audience in the next panel is Dr. Bruce Patterson, who has a diagnostic tool. He absolutely has one. I believe it's the right one. And thanks to Dr. Bhattacharya, who's going to let him continue to prove that that's the right one. The Secretary talks about, confirming other people's studies, and that's exactly what we're going to do. And the great thing, it helps delineate the difference between reactivation of Lyme's disease versus long COVID. So you're right. Outside of the ivory towers, there are people that are out there at warp speed time trying to solve the problem. And of course, my mentor here, Dr. Redfield, has also helped my loved one in kind of quarterbacking all the different approaches out there, and just kind of keep the keeper of all knowledge, and just always brings a word of hope to all of us. So I'm honored to be here, and we're gonna whip this thing, Mr. Secretary. We're gonna get to the bottom of it. Thank you.
Great, thank you, Senator. Great to be here, and my name is Marty McCary. I'm the FDA Commissioner. Mr. Secretary, thank you for making this a priority. We have been talking about so many competing important areas in healthcare where we desperately need to push the field towards a cure, and this was a massive priority for this Secretary, so that's why we're here today. Thank you. Long COVID is real. It's been underestimated and overestimated. We are here today to try to help those who are suffering from long COVID. We've spent $1.5 billion with essentially nothing to show for those dollars that were allocated. A lot of hospitals got rich with more MRIs and CAT scan revenue, but in the end, the people suffering with the condition are still struggling. We do know that we have some data points. The presence of long COVID appears to be proportional to the duration of COVID illness and the severity of COVID illness. Thank God both of those have decreased significantly over time, and so we don't see as many new cases today as we did in the past, but people who developed their long COVID symptoms in the past still deserve answers. They've become forgotten to many people. We do know COVID illness is an antibody-mediated phenomena, and antibodies can do a lot of things in the body that are not always anticipated or recognized early on. And we know that COVID illness creates general body inflammation. Guess what most illnesses in the entire field of medical science are due to? generalized body inflammation, insulin resistance, and metabolic dysfunction. And so maybe we are seeing some of the same common principles that could apply to other illnesses if we can crack this code. So I'm here to learn and to listen, but we are committed at the FDA to supporting this agenda. So thank you.
I'm Jay Bhattacharya. I'm the director of the National Institute of Health. When I was in the Senate hearing for my confirmation, as I was leaving the Senate floor after the hearing, a long COVID patient came up to me and said, "I'm desperate. Please help." And I assured her that we're going to find an answer. The National Institute of Health, it has a long history of finding answers for patients. As the representative of the Ivory Tower class here, Mr. Secretary, let me just say, I want to make sure that we're not just in the Ivory Tower. There's folks in the room who have learned about long COVID in the Ivory Tower who've devoted their careers to trying to get answers. But also we have to acknowledge that we have not made as much progress as the patients that we are representing deserve. For the NIH, I don't want to wait to know everything about the physiology of the disease, the pathophysiology of the disease. I don't want to wait to be able to get the perfect diagnostic test before we start to have like real answers for patients. I can entirely agree with you, Mr. Secretary, about listening to the physicians who treat patients, listening to the patients themselves, and then I want to see that those ideas are incorporated in our research agenda. Actually, one of the things I've learned since becoming NIH director is that we've shifted how we're doing our investments in long COVID research toward more practical trials. And we're running, I think several of them now, but we need to expand them to more. I've heard so many great ideas from some of the physicians in the room and from patients themselves. It's going to be a collaboration. It's not going to be us telling you from the Ivory Tower, here's what's real, what's not real. It's going to be us listening to you and our expertise helping to sift, the answers so you can have, the next time we have a commission a year from now, it won't be 20 million people suffering. It'll be, 20 million people with answers, and getting better.
I'm Jordan Vaughn from Birmingham, Alabama. I am the founder of the Microvascular Research Foundation for Long COVID. I'm actually just an independent physician that had the resources to try to help people. And a lot of what's driven me is a lot of the data from the academic world, but being able to utilize that data and apply my understanding of mechanisms of medicines and actually discuss with the patient and figure out ways to help them based on their symptoms, the knowledge we get from the NIH, but also reusing medicines that we know help in those areas. And I think that's one of the things that drives me the most is a lot of solutions. Even there are things that will come, I think, but there's a lot of things already out there on the shelf that we need to evaluate and utilize and actually are very available for people and is very effective in many ways, especially in again, I've treated about 4,000 people. And just the data that I have within my clinical cohort is amazing, but it also informs me on when things don't work and when they do work. And so in many ways, I think actually having a clinician-patient direction upward and actually suggesting models and pathology markers and that is actually the direction it needs to go instead of from the top down. I think actually it's such a patient symptom-based disease with multi-systems that it's going to be very hard unless you listen to patients. And actually a lot of the things that I've learned is actually just by keeping my ears open and spending time with patients and believing what they tell me. And I think that is something that you're not going to get from a textbook. And in fact, a lot of the time what the patient informs you, you utilize your medical education to come up with ways that could happen and then try treatments that might work for it and they become effective. I mean, it's a very different pathway than the classical pathway, but especially when you're talking about probably something that's going to require multiple medications and has multiple systems involved, a monotherapy is probably going to be very hard to come up with. And I think we need to look at it in a very different light. So thank you.
Good afternoon. I'm Michael Paitis. Mr. Secretary, thank you for the invitation. I'm an obstetrician. I'm actually a maternal fetal medicine specialist and a physician scientist. I've been on the front lines for COVID, for acute and long COVID since the beginning. And I desperately wanted to do something to help our patients from the very beginning. My laboratory focuses particularly on brain injury work. And we've developed a therapeutic for acute and long COVID, and we're in the preclinical setting, and we're hoping to go into a clinical trial. And I hope I can be of help to this group.
What, can you tell what the treatment is?
Sure, it's a 15 amino acid peptide that is called SpikeNet that blankets the spike protein. And we developed, because in the early days, I wanted to develop an animal model that would help us to actually work with this in a safe way. So we developed a BSL-2 model, which means that it's not as risky, if you will, as working with the SARS-CoV-2 virus. And that allowed us to help understand some of the pathologies. And we then went ahead and studied other aspects to it. So now we know it's different effects, not only in binding the virus, but actually what it's doing to help heal and reverse some of the changes that are occurring in different organs.
Are you finding the same level of COVID in vaccinated versus unvaccinated people infected, or what are you seeing in that area?
Yeah, that's a great question. So all of this in the preclinical model, is not with using on the vaccine. What we're seeing now, clinically, is that we have a mix of patients that have been vaccine naive and patients that have had it. And I am seeing this in the hospital routinely, not in the high numbers and that we saw initially, but certainly we're seeing it.
Hi, everyone. David Petrino. I'm the Nash Family Director of the Cohen Center for Recovery from Complex Chronic Illness in New York. We're a hybrid clinical and research center in New York City that treats long COVID, chronic Lyme disease, vaccine injury, and other infection-associated chronic illnesses such as ME/CFS. Long COVID first came on our radar in April of 2020, shortly after we'd been hit pretty hard in New York by COVID, and we started to notice some of our patients weren't recovering, so we stood up a clinical program. And since then, we've seen over 5,000 people with long COVID at our clinic. And we recently released a 167-page guide to assessment, intervention, all in an insurance-covered clinic. So we, even in the manual, we cover what CPT codes to bill, how to write. So
what are you finding that works?
So what we've done in the handbook is similar to what you said, Secretary Kennedy. There's 300 symptoms, right? But there are far fewer drivers, and so when we think about what could be causing the symptoms, there's autonomic dysfunction, there's vascular dysfunction, which Jordan does a lot of work with, there's immune dysfunction, there's viral persistence, there's reactivation of other viruses. So what we advocate for is an approach where, also as Jordan said, your patient is your biomarker. You listen to what they're saying. You take a few blood tests. You say, oh, look, I'm seeing EBV reactivation strongly in this person. Their spike antibody is really, really high. Maybe this person might benefit from a combination of antivirals, such as, we've been working with a physician named Skip Pridgeon, also, who pairs valacyclovir and Celebrex and Paxlovid. And his results have been really, really quite strong. And so we're trying to bring some of his work into a randomized controlled trial so that we can go to the FDA and say, hey, here's some good quality data suggesting that this really moves the needle. One thing, if you take anything away from this meeting, There's no silver bullet. There's not going to be one drug that undoes everything for long COVID. We really have to look at each patient individually, the same way that we do with HIV care, the same way that we do with cancer care. We need to really understand the uniqueness of each patient.
Dr. Redfield, what are you seeing that works in your clinic? And do you have interactions with other doctors like these?
Well, I do interact with them. Jordan Bond and I work very closely together. He's taught me a lot, and I think I've taught him a little. I tell people it's hard for me to say that he may be better at this than me because I'm pretty cocky. But again, the symptom complex is important. So I focused more on cognitive dysfunction and immune dysregulation. And in that regard, I've looked at ways to try to trick the immune system to reset its set point. So I use some of the earlier drugs that I had used for treating HIV infection. For example, a drug called Maraviroc, which I use quite frequently and have had some fairly dramatic impact on cognitive function in people who literally are so cognitively impaired that they can't speak in more than 2 or 3 words at a time, and been able to get them back to speaking normally. The other thing we've done a lot working with Jordan is become much more aware of pelvic vein congestion in patients, which who would have believed that I have patients that present that really feel like they're suffocating, and it's not a comfortable place to be in a room with these patients because they're 24/7 feel like they can't breathe. And yet their hearts are normal and their lungs are normal, so why can't they breathe? And Jordan helped elucidate and helped teach me, and I've followed up on it, is their problem is they're not returning blood to the heart and the lungs. And the reason they're not returning blood to the heart and lungs is because the integrity of their veins, they can't stay open under the pressure of an artery that's over top it. So we see a lot of pelvic vein compression. And what we end up doing, we both have a mutual patient today that's having the procedure done in Denver. Believe it or not, what we end up doing is putting a pelvic stent in the iliac vein to keep the vein open, and it resolves their symptomatology. So there's all different times. You got to really decide what you're going after. For me, largely it's been cognitive dysfunction, where I have a lot of high-performing individuals that no longer can function their executive function. And how do I get their executive function back to the point that they can maintain their job? And again, as I mentioned, the drug I probably use a lot is Maraviroc, rapamycin, probenecid in a combination. And again, all repurposed drugs, none of them approved for what I'm using, but I've had pretty good results in about 70% of the patients. And then, if they have the pelvic vein congestion syndrome, getting intervention radiology or peripheral vascular surgery to evaluate them and potentially put stents in. We have other patients that, as already mentioned, they have a tendency to reactivate other viruses, the herpes viruses in particular. Are there ways that we can help them regain control of their replication of herpes viruses? So it's a very complex disease. It is going to be important to limit the symptoms into categories and to try to compare apples to apples. Because if you just take people, quote, with long COVID, the last thing I'll say on this is there really is probably a difference between patients with post-mRNA injury versus people that have post-COVID symptoms. I will say my post-mRNA injury, which is a real thing, it's real, contrary to what a lot of people think, it's real. Those patients have a tendency of not improving. They just don't seem to be improving. I have a number of patients now that are out 5 years. It's painful. The COVID infection patients do have a tendency to improve over time, despite me doing something or not doing something, although we try to accelerate that, particularly for those people that have so severe cognitive dysfunction. I can tell you the one lady, Joy, is a beautiful woman that I take care of, executive function, mid-50s. She got to the point that she could only speak in about 2 words, 3 words at a time. And she came to see me, And I told her at the end of our first visit that she was the sickest person from cognitive dysfunction that I'd ever seen. And she immediately burst into tears. It was very awkward, and she left. I told my wife the story, and my wife lectured me on being more caring.
You need to improve your bedside manner.
Improve my bedside manner. And so Joy came back the following week, and the first thing I did was I apologized to her, and I said, I told you the truth, but maybe I could have done it in a better way. And Joy looked at me, speaking in two-word blurbs. She said, Dr. Redfield, I didn't cry because you said I was the sickest patient that you've ever seen. I cried because you're the first doctor that acknowledged I was sick. And that's the problem with most of these patients. I'd say 5 years ago, 95% of my patients came to me from psychiatry. They were all told it's a problem. Now, some of them actually get to me before they see the psychiatrist, but these patients have really been told there's nothing wrong with them. It's anxiety, they're making it up. No, it's organic. And Joy, I got to put on this combination, Maraviroc, rapamycin, probenecid. And within 3 weeks, she was speaking normally. Her insurance company decided not to renew the prescription. Within 3 to 4 weeks, she couldn't speak again. We got her back on the medicine, and within 3 to 4 weeks, she was speaking normally. So there are things that work. I don't know why they work. I do think one of the problems with COVID that I'm more of an expert on is this post-inflammatory immunoregulatory problem, and how to get the immune system that's stuck over here, how do I get it back in the middle so that individuals can function more readily.
Mr. Secretary, if I could just quickly, I'm trying to talk to the folks at home now on this pelvic congestion syndrome. And it's a pretty easy way to self-diagnose yourself if you've got this or not. And it's maybe just as simply if you feel better in a swimming pool, if that gives you some relief, would that be, what else can they do at home just to sort that out?
Yeah, a couple of defining things are non-recovery in the legs. A lot of them additionally have lots of fullness below the belly button. They also have a lot of POTS-like symptoms because of the preload failure of the right ventricle, meaning you're not getting blood back to your heart, which also additionally means pulmonary perfusion is compromised, which makes you short of breath.
What can they do at home?
So the main thing would be, yes, do you feel better in water? But also, a lot of these people, a lot of us don't realize the reason we sleep horizontal is because of the venous system, because it's a low-pressure system. So most of these people were people that woke up ready to run, ready to go. And a lot of them now will say, look, it takes me an hour in moving in the morning to get going. And that's a good signal that there is a venous basically venous stasis or venous issues. And again, I go back to this that I didn't even realize 72+% of your blood is in your venous system, and it's not good blood. It's low oxygen, it's inflammatory, it's coagulable. And if it's not moving, in a sense, it's like your sewage not moving.
Yeah, one of the things for your website, Mr. Secretary, which would be so useful, Jordan and I have talked about it, is just to have these patients tell their story. I mean, when you hear this story, I mean, when I first heard it, I didn't understand it. I mean, but now that I've heard the story, I can pick it up like that. You guys have pelvic vein congestion, and we finally get them to, a professional vascular surgeon or a special radiology, and lo and behold, we find out they're 85, 95% compressed. So I think patients hearing other patients' stories can begin to position themselves correctly. Because the average physician, I think, is not educated about this at all. I mean, I won't tell you how many people think that, this can't be true.
But me and Dr. Redfield we argue about what's causing it, which I think is where the NIH comes in. It's okay, we see this phenomenon. It's usually happened in women historically. Now about 40% of my patients are male. Usually they're athletic males that are hypermobile, a little more flexible than average, probably some laxity in the veins. But why? And I'm a vascular guy, so I think the vasovasorum, the small vessels to the veins, are being compromised, which compromises the smooth muscle integrity of the veins. Dr. Redfield agrees with me, so it's probably right. I'm just kidding. But we need those kind of...
I tell them that the veins major receptor is the H2 receptor, and basically it's a problem with the spike protein dysregulating the H2 receptor and causing inflammation in the bowel wall. But we don't know what the...
Yeah, and that's where I'm saying the clinical things, the phenotypes we're seeing, being able to have some type of mechanism that's really in the background, picking up and seeing these kind of phenomenon that drives translational research to say, what the heck is actually going on here? That's kind of my very different than the top down because you're looking at it from the patient reporting it as opposed to some phenomenon above.
So one of the things that the Recover TLC, this is this sort of the next step in what the NIH is trying to do with long COVID is we had essentially a listening session, a formal listening session where we had submissions from patients, from doctors, and we got 403 submissions about drugs, 64 on diet and nutrition, 29 on manual and physical therapies, 27 on complementary integrative health, and then 28 device submissions, and 21 other, which is, I mean, I thought I'd got through all the categories. So the point is that there's a lot to study, and the question is, like, for us, it's prioritization, right? Like, well, how do we decide which of these are the most promising? This is partly why I said earlier, I don't want to wait. I don't want what we did in HIV, where we're like telling patients just wait till the randomized trial, wait till the randomized trial. We have to be pragmatic, right? There's so many different sort of conditions, and we have 4 that we're currently doing, four trials. We're doing Recover TLC, low dose naltrexone for some folks, GLP-1 drugs actually again works for some folks, stellate ganglion block, and then baricitinib. So those are the 4 we're doing, and it's not enough. I have to say it's a good step forward because we're not waiting to find a full characterization of all the. You can hear among these august doctors that we're still like struggling to figure out exactly what the right mechanisms are. And you guys have seen hundreds and hundreds of cases. So,
well, if I may, I mean, we're currently running dozens of clinical trials ourselves, interventional clinical trials, randomized controlled trials, without any NIH funding. The reason for that is, and with respect, I grew up in the NIH system, so, NIH is very good at doing incremental innovation, which, as Jordan mentioned, that's what we need to understand mechanisms. That's what we need to understand things. But when it comes to, and I'm an implementation scientist, so I know these numbers, but when it comes to, things that the NIH have funded, we go from bench to bedside on average in the United States in 17 years. That is too long. And so I think we need to advocate for more public-private partnerships. We need to get drug companies involved. We need to, there's a company called Invivyd that we're working with right now that produces a monoclonal that could be helpful for both long COVID and for vaccine injury because it can, neutralize spike protein that is circulating in the body. We have not yet had a good-sized mechanistic trial of a monoclonal to neutralize spike protein. This is an urgent need, and this is something that I think we can achieve rapidly through public-private partnerships. We can go to the FDA and we can say, these are the sorts of things that we need to get, emergency use authorization and urgent labeling for these patients who are currently paying out of pocket. I met with a patient just yesterday, went out to New Jersey, spent $30,000 on, a monoclonal infusion. That's not achievable, to most people, and not even 1% of people.
Well,
if I could just echo one comment that I think, Mr. Secretary, for you to reflect on, and I've mentioned it to Jay, I think it's so important to get the private sector involved. All right? When I think about how we motivated, for better or worse, the vaccine companies in Operation Warp Speed, we got the private sector involved. I remember Tony Fauci and Collins said that we didn't need to do that, just give the $15 billion to NIH and they take care of it in 3 to 7 years. And I made a lot of friends that day. I said, yeah, it will probably take 7 years if that's how we do it. I think we got to get the private sector involved. There's a lot of private sector. I know a number of companies that have very exciting, innovative stuff. And we've got to get them involved. Even in this little room right here, you're looking with clinicians in long COVID, between 1, 2, 3, 4 of us, we're probably taking care of over 15,000 people. I mean, it's not that complicated to put a consortium together and then, partner that with the private sector to bring some of these new innovative therapies. Well, I think that's part of the things you have to engage them. I mean, it's not everybody in the private sector is adverse to using repurposed drugs.
But that's something the NIH ought to solve. mean, that's something we haven't done enough of, and it's something. I mean, I hear you. You're right, absolutely right. We need to do this much faster and be more agile, and with private sector collaboration, there are mechanisms inside the government to do that, and we just need to use them more.
Yeah, I would just follow up with that. I've had 3 now of STTR SBIRs, and that's where you really get at that private and academic partnership, which supported by the NIH, which I think is a great program for drug discovery and acceleration getting to clinical. The second comment I just wanted to make is, you have a number of OBs and GYNs across the country. We do ultrasound all the time. I'm looking at thinking logistically, we can just engage our colleagues to incorporate this because we're doing this all the time on the uterine artery and the pelvic veins.
I just want to add, that's why I wrote the stem cell bill, was because we were waiting for FDA to approve ethical sources of stem cells for treatments. And so writing the bill, getting it passed unanimously, both in the House and the Senate, I'd love to do something at a federal level that allows, and it's not just going to help with the long COVID, it helps with autism and dementia and Parkinson's and all these other different diseases. I believe the peptides too will also help with that, along with hyperbarics. So the congestion stuff that was going on, my hands and feet were pretty much black and purple. But when I did hyperbarics, it brought back all of the circulation. I also phlebotomized. I think there's a lot of things out there that we can look into that are going to help us. And I mean, I was waiting for doctors to help me and was not getting the help, or even the hospitals. I had to take it into my own hands and into my own kids. I have 4 kids that all have it. And we have vaccine injury. We also have long COVID, from COVID itself. And so working with some doctors that think outside of the box, Dr. Jones was amazing. He's the one that found the monoclonals. He ran all my interleukins. And then figuring out the hyperbarics, and then the stem cells and the peptides. So there's hope. And that's the thing, is when I felt a little bit better, it gave me hope of knowing this isn't permanent, that we can find things that are going to help us to get even better. So
I would say in this disease process, most patients probably know more about it than your typical physician or internist when you walk in. There's very few diseases like that. And a lot of actually the ideas or things that they come to, sometimes just listening to what worked actually creates ideas in my head on why it worked, if that makes sense. And I think listening, again, getting back to listening to patients, but it's amazing right now the resources that patients have to be able to find out about their issue. The problem is when they try to find something to execute help for the issue that they've discovered is very difficult because physicians are unaware that this is causing issues, especially even within their specialty and domains. And so imagine going with a disease that you know you have and a physician that, first of all, may not even believe in it. Second of all, may have never even heard of it. What kind of help are you going to get unless you have a physician that's willing to learn and then try things?
I do think education is important there, Jordan. I mean, great point. But, I did a series, when we released our handbook, I did a series of educational talks across the West Coast to 1,000 PCPs, because I really think PCPs are going to solve all our problems here. No pressure on the PCPs, but they're the people who, when you walk in the door and say, look, I got sick 2 weeks ago, or a tick bit me, and I haven't felt the same since, they're the ones who should be identifying, oh, you have chronic Lyme, you have long COVID, you have ME/CFS, or chronic EBV. And we got to 1,000 PCPs in that tour, so we really went for it. And 30% in the door at our pre-seminar interview did not believe that long COVID was real. So that they were happy to mark themselves on a survey and not believe in the authenticity of this. An hour and a half later, 0% said that. And it was just presenting good quality data to them and saying, this is what and also this is a plan. Here are the things you can try when someone comes in your door.
And I think this gets back to, we do need a good diagnostic tool. And I just can't emphasize enough the mental help of being told that, yes, you're not crazy. Let's just be frank here. These patients have been told they're crazy. There's nothing wrong with you physically. To have a test that confirms you know, oh, it's Lyme's disease. Okay, great. And I think that maybe we have some of those secrets now unfolding as you say there's 70 symptoms, 150. You probably are starting to put them in buckets now. And based upon those buckets, is there a correlation with some of the testing that we're doing? I'm looking at Dr. Patterson to come and tell us the next roundtable. And then your primary care doctors, you're get them to first base at least. We want to get the PCPs to first base with a little bit more data.
So I think this roundtable already is a significant watershed in validating this disease, putting a lot of information on the table. I'm learning a lot. Mr. Secretary, I'm very grateful that you convened this. And you also asked us to build a website to scale this meeting up into a national level and provide a single a platform where patients and providers and pharma companies can all share information about symptoms and diagnosis and repurposed drugs and treatments and probably a lot of other things that we haven't thought of yet. And we have our Chief Technology Officer of HHS, Zach Terrell, here listening. He's going to build Secretary's asked him to build a website at CDC for all this information. We have Kristen Honey, our Chief Data Officer. We have Dr. Willie Churtman, our Science Policy Advisor. We're all listening. I'm learning a lot, and we are going to scale this up.
I'd like to add something if I can.
ask one?
Yes, 100%.
Sorry,
Yeah.
my question was, are any of you seeing an interaction with mold?
Yes, I think along with, as Dr. Redfield mentioned, there's this immune dysregulation, and I think immune dysregulation makes your body more susceptible to everything. So for instance, as you mentioned, your chronic Lyme meeting roundtable, something you can take into that is we have data to suggest that a significant portion of our long COVID patients are now testing positive for reactivated Babesia, which is a tick-borne pathogen. And what we think is that they were carrying that pathogen, that parasite, for a very long time, and SARS-CoV-2 reactivated because where does Babesia hide, our vascular people? In the vasculature. It hides in the endothelium. So spike protein agitates the endothelium, and so these other pathogens get reactivated and agitated. And similarly, this immune dysregulation, the immune exhaustion that people with long COVID experience, also make them susceptible to mold exposure, make them susceptible to mold injury and other toxins as well.
And there's cells in our body we call mast cells that are very unstable in people with long COVID. And what they end up doing is causing all of this allergic symptomatology. So mold, whether it's mold, hyperreaction, I will tell you that when they get intercurrent illnesses, patients who get an intercurrent respiratory illness, they get it much worse when there's with long COVID than say before they had it. So there's clearly a hyperreactivity of the body to allergens, to infectious diseases. Jordan and I do a number of things to try to stabilize the mast cells in the human body. A lot of repurposed drugs that we know can actually help stabilize these cells, and patients do get a lot of benefit from it when we stabilize their mast cells.
Devin, did you have a comment?
Yes, I just didn't want to lose track of the virus because the virus persists and people get reinfected as well. And that's a big problem for people with long COVID. And I know we want to characterize everything, but when I had chronic Lyme, my chronic Lyme symptoms didn't present like somebody else's, but we still had the same underlying problem, which was Borrelia was chronic. So I just want to be cautious about putting everybody into groups when the main underlying problem may be the same thing. Even though there are reactivated pathogens and damage and other things going on, the virus itself, and included with the spike, I think we need to keep a great focus on that because Lyme's the great imitator, and I think long COVID is the greater imitator.
I think it's a real important point. I mean, I'm sort of a clinical virologist, and I will tell you 4 years, 5 years ago, I would have argued pretty aggressively that there's not viral persistence with COVID. Now, in the last 2.5, 3 years, I'm totally convinced that there's viral persistence in long COVID. A number of the patients that they failed to clear the virus. This is a chronic viral infection. And so then that raises a whole different ways to approach it. How do we stimulate the body to facilitate viral clearance? And I think the group at Yale's done some really good work. I think there's a lot of evidence now. We have a paper that we're going through review now that's highlighting all the evidence today that there is viral persistence. And that's important because as we get into what's the pathogenesis of long COVID, I think more than we appreciated, it's the lack of viral clearance.
And to that point, just earlier this year, a consortium of us came together and published in Lancet Infectious Diseases a roadmap. So for anyone who wants to use it, FDA, CDC, NIH, a roadmap for how to address viral persistence in long COVID cases, which really talked about combination antivirals, long duration combination antivirals, mixing antivirals with monoclonals, because as we know, once a pathogen is persisting, i.e. once it's in the tissue, it's much, much harder to eradicate than just, 2 weeks of Paxlovid or, boost your immune system for a little while and hope for the best.
And one of the important mechanisms that we have as humans to clear pathogens is an aspect of the immune system we call the cellular immune system. And I think if you watch closely, there'll be more and more data coming out that there's significant defects in cellular immunity in people with long COVID. And that opens the possibility, not only could you use antibody, but could you look at ways to trigger their cellular immunity? Because it's really cellular immunity that our body uses to clear these pathogens at the end of the day. So I'm very optimistic that with significant investment in the science of this, and Jay and I have talked about this, is that we can really go after therapeutic strategies that are based on a pathogenic understanding. I think I argued with Jay probably 5 years ago, and I told him there's no viral persistence, this is self-limited virus. Well, I was wrong. There probably is viral persistence.
I think Dr. Redfield's optimism is a good place to end this session. We're going to have in half an hour. We're going to start our next session on innovation, and I welcome all of you at home to rejoin us, and thank you all very much for being part of this.